It's very common to have parents who, because of their kids' distress, are doing errors of kindness and wanting to make things smoother and better and get into a pattern of helping accommodate the 2-hour nighttime ritual, and are really uncomfortable with the idea of starting to pull that back because their kids get so distressed. And then the kids learn that if they get really distressed, their parents will fold and come back and help them. And so you get this escalating pattern and can end up with kids who are threatening suicide or getting really aggressive because they're so distressed by their OCD symptoms, and they've learned that that will engage the parents in rescue behavior.
Welcome to the Mind Meets Medicine podcast, where we believe the future of healthcare is mind meeting medicine. Hi, I'm Kaila, a licensed therapist and founder of a mental health care clinic.
And I'm Dr. Sir, a board-certified psychiatrist.
Together, we will join the fields of medicine and psychology to provide education, elevate guest perspectives, and foster curious, informed conversations.
The contents of this show are for informational, educational purposes and are not intended to replace professional, medical, or clinical advice. This content does not establish a patient-provider relationship. Always seek the guidance of a qualified healthcare provider for any questions you may have regarding your health or treatment. If you're experiencing a psychiatric emergency, please call emergency services or go to your nearest hospital immediately.
Welcome back to Mind Meets Medicine. I'm Kaila.
I'm Dr. Sir. Today, we're joined by a very special guest, Harvard-trained board-certified psychiatrist who's spent many years working with kids, young adults dealing with anxiety, OCD, and tic disorders. He's held senior roles at Cornell Medicine and New York Presbyterian, co-founded a specialized pediatric OCD and anxiety clinic, and is a sought-after speaker on psychopharmacology nationwide. And if that wasn't enough, he also consults with architects on designing behavioral health spaces and healthcare systems, because he believes the environment where care happens matters just as much as the care itself. Welcome, Dr. Justin Mohatt.
Thank you. I'm so honored to be here. Longtime listener, first time caller.
That's great.
Yes, we're really excited and happy to have you here. And I think we'll get to know you some, as well as dive into some specifically OCD topic areas and talk about some of the mind and the medicine on that.
Sounds great.
But sometimes that we ask our guests is just a general open question. What's on your mind today?
Well, personally, I am riding the intermittent reinforcement schedule that is the San Jose Sharks right now, and in a high point momentarily, but we'll see where that goes. Professionally, I think I spend most of my days working with adolescents and young adults. And I think the stuff that's on my mind most with respect to that work is just a general level of concern for our youth these days, and what seems to be a pattern of increasing sort of social disconnection, and sort of where is that going to lead? I know it's not exactly related to our specific topic today, but it's something I think about every day. I see these kids who I think a couple generations ago would have been much more socially connected than they are. And they look so successful in other ways, but they're just not in relationships in the same way. They don't have the same level of friendships. Their days are hyper organized and scheduled and sort of task oriented, and their connections with their peers are much looser. When I do see a kid who has very close peer relationships and like a best buddy or a best girlfriend, I sort of breathe a sigh of relief because it's less and less common. So,
do you feel like that's a collective from like where we are in the world, or are you seeing that across? Because you worked in different states. Is that a generational thing that you're noticing?
Yeah, I don't think it's specific to the Bay Area or the Monterey Bay area. I think that it's a nationwide issue, and the statistics show that kids are, in some respects, the metrics look good. They're not getting in as many car accidents. They're not drinking as much. They're not having sex as early. There are less early pregnancies. There's sort of like all these things that look good. And under the hood, though, is a pattern of isolation and social disconnection. And, they're not getting into motor vehicle accidents because so few of them are getting driver's licenses when they turn 16 compared to the past. And that's a national trend. It's not specific to our area or a particular socioeconomic kind of demographic. I mean, I think there are certain things that are probably more local, including kind of what's expected of a kid in terms of extracurricular activities and sports and stuff. But I think it's truly a national problem.
Yeah, that makes sense.
And when we think about what is important for resiliency and building resiliency, I think one of the key components is social connection and a sense of meaning and purpose related to community. And so like that makes me nervous.
Yeah, I feel like I've noticed more even longevity data being driven in large part about social connection and community as opposed to, what supplements you're taking or.
Right.
Yeah.
What IVs you're doing.
Yes.
And the mode with which I think kids are connecting with each other is online, or through their phones, through their screens. And something I've noticed is just that the relationships can seem really fragile. The peer relationships, they change week to week, and it's hard to keep up with all the happenings of all the friend group dynamics.
Yeah, absolutely. And they're not just hanging out. That after school free time hanging out with your friends is not typical anymore. And usually their hangout time or their friend time is around some organized activity that they share. So musical theater or sports or debate, whatever it is, that's where they're seeing their friends. But when you ask, like, well, do you see your friends and hang out on weekends? No. And they're not saying it with regret. They're not saying, oh, I wish I could. It's just matter of fact. And it's kind of the life that these kids are leading now. And if you ask them why, often they'll say, well, they're busy with their activities. And I'm busy with my activities. And so there isn't time for that. So I worry that, there's the technology piece of this. And then there's also just kind of what we expect kids to be doing with their time now versus what we used to expect kids to be doing with their time. There's so many layers to it, right? Because if you're also worried about getting into college, now, the idea is you have to be doing a million different things, which means there's no free time to see friends and develop relationships. And so I think we send kids off to college often not prepared for the tasks of adulting. I'm a big fan of Jonathan Haidt's.
I know. I was about to say, have you read his books?
Yes. We had him come and give grand rounds when I was the division director at Cornell, and it was phenomenal. And I think he is so right to be ringing the alarm bells that he's ringing. And what he's saying is, I think, prophetic in the sense that we're seeing it come true.
Something I really appreciate is he's been saying the same things, backing it up with research. And this isn't like he just started last year. These are things that he's been saying for many years.
Yep.
And now incorporating what happened with the pandemic and just development. And I do think this ropes into our conversation today about, adolescent and OCD in children, because this is, I think, a therapy generation. This is the generation of kids that is normal to go to therapy. A lot of them do. And a lot of them know that their friends do, and they're in a little isolated bubble, which he talks about, sending kids to go buy something or bike home from school on their own or go into a shop and like purchase their own, snack. Like even ordering is hard. So
Yeah. Have you seen that Japanese show with the little
Yes,
kids that
yes.
get sent to do tasks?
Yes,
I
it's
love it.
so cute.
I don't,
Oh,
yeah.
I think it's on Netflix.
Yeah. I forget what is it called? I forget what it's
Oh.
called. It's worth looking up.
Okay.
You would actually really like it.
It's phenomenal. And things that unfortunately in our country, if somebody did that with even a 7 or 8 year old, let alone the age these kids are, someone would report them to Child Protective Services for sort of not being on top of their kid in the right way. So,
yeah. We'll maybe look it up and we can add it to the notes too.
It's adorable.
it is.
It's like little kids, like 3-year-olds.
Like going into stores
Yeah.
and
Yeah, they're like walking down
to-
the street to go to the store to pick up something that their mother or father sent them to go do, and then walking home.
And they're capable.
Mhm.
Yeah.
It's very sweet.
So do you want to say a little bit about your background and what you like to work with and kind of maybe where you're at this moment in your career?
Mm-hmm.
Well, my background, it's interesting. I didn't come to this specific field or area of my field around OCD and related disorders by virtue of any kind of personal experience in that realm. I did come to the mental health field by virtue of that. I think, I come from a long line of mental health providers. My dad was a psychologist. I have an aunt and uncle that are both psychologists. My brother's godparents are analysts. Like, it just has come down. And I didn't go into medicine thinking that I was going to do psychiatry. I was a serious athlete as a kid. I spent a lot of time in the physical therapist's office and the orthopedist's office. And that is actually what got me into medicine. I thought I was going to do sports medicine.
What was your sport?
Swimming. And so I had lots of shoulder issues.
Yeah.
But, in medical school, you rotate through everything, and you also start realizing culturally which fields you fit best with. And I very quickly realized I really wasn't cut out to be an orthopedic surgeon in terms of my personality and stuff. And ultimately, when I did my psychiatry rotation, it just clicked, and I realized how much I enjoyed it compared to my other rotations. I think I had been fighting this family legacy for a long time in a very adolescent way.
You were trying to individuate.
And I had to come to terms with the fact that this actually was very interesting to me, and not just because it's what my dad did. And so, but I always knew I was going to work with kids. Even growing up, when I thought about being a doctor, I was going to be, I envisioned sports medicine with student athletes like I was. But I also, throughout medical school, I was like, oh, well, maybe I'll do pediatrics. Maybe I'll do pediatric interventional radiology. That was a thing for a while. And I don't know why specifically, but that's always been because I think I feel such deep empathy for kids that are suffering. And then in our field, I feel like we have such an opportunity working with young patients to make a huge impact in a way that's much harder when somebody has been struggling with these symptoms for 40, 50 years and is just coming to treatment at that point. And so it feels like a real opportunity. And I feel very grateful to be able to work with young people and their families. And then in training, I got exposed to amazing supervision and training around OCD and related disorders. And through that experience, realized this is like the very narrow area that I'm most interested in, and just kind of pursued that over the course of my career, which I've had multiple chapters on. And, at this point, I'm back in private practice after a long time in academic medicine and then in sort of hospital leadership positions, focusing back on clinical work and doing that in our local community. And then this sort of, I don't want to call it a side gig, but other kind of piece of my life, which is building this consulting around behavioral health care, facility design, and making sure that we have a new generation of spaces that are designed to be an active treatment intervention themselves, not just an afterthought.
That could be a whole other episode. That is like my, when you said that, when you told me that the first time, I was like, oh my God, that's a thing. I didn't even know that that was a real gig that somebody could have.
It's an amazing field, and there's so much happening these days. There's a real robust reinvestment in behavioral health facilities, in part because the existing facilities are aging and have been for quite some time. And I think an appreciation nationally around the need for mental health services that has finally kind of risen to the level where there's investment. So in California here, there's a lot of investment happening in new facilities, both private and public. And nationally, you're seeing that too. A lot of the large academic centers are building new campuses for behavioral health or doing significant reinvestment in their existing structure. So there's a lot to talk about.
Yeah. And creating spaces that feel like welcoming and not stigmatizing and cold and clinical. And it's awesome.
Yeah, spaces that provide patients with a sense of dignity and while still being safe. Yep. For everybody. It's safe for patients and for staff. So
as you deepened your work in psychiatry and with children and adolescents, what pulled you into the OCD world? What was interesting for you?
You know, I reflect on this a lot, and I don't really know the answer to it. It just grabbed me in some way. And I do think it had to do with having an amazing supervisor in my child and adolescent fellowship, where I got to work with very complicated patients that had co-occurring OCD, ADHD, Tourette's, and see the impact that our treatments could have. And also an area where I felt like there was a lot of kind of misunderstanding and treatment sort of as was that wasn't really based in the evidence, and kids that were unnecessarily struggling because there weren't enough people that really understood it and knew what to do with it. So I think it was those combination of things. And then when I went out into practice, I sort of purposefully built that aspect of my practice. And then when I got to Cornell, it was just a wonderful kind of confluence of events in that I was moving to New York, looking for a position, wanting to get back into academic medicine. And Cornell at the time had a newly recruited division director and vice chair for child psychiatry, who this was his area of passion and focus as well. And so we worked beautifully together, and he was a tremendous mentor of mine. His name is John Walkup. He's the chair at Lurie Children's Hospital at Northwestern now. And so we were able to, along with one of my psychology colleagues from UCLA, actually build a really tremendous specialty program there that continues to this day. So,
yeah. I remember my first OCD case I was in second year resident, I think. For you listening, if you don't have as much context for psychiatry training, there's a lot of variations now, but kind of the more standard traditional way of structuring it is 4 years. You do 2 years inpatient and the second 2 years outpatient. So 2 years in the hospital, typically locked involuntary units, and then 2 years in kind of your standard clinics and doing therapy. And so I had essentially trained for maybe a year and some change before I saw my first OCD case, because people don't usually present to emergency rooms or inpatient units with OCD. And so I think I felt similarly grabbed by it. I was like, what is this thing that I've never seen? You know, I've seen 1,000 patients, but I've never seen this before. And that person had some suicidality, which was a part of their constellation of things and how they ended up there. But then I kind of went down and read all these papers, and I was like, there's a whole world here. There's a whole literature here. And then so we actually had a partial program for OCD for adults. And I did that for a year, half of the time doing exposure response prevention, or ERP, as a therapy coach. And then the other half of the time doing the medication management. And I think that's was a awesome training, a deep understanding of it in a way that I didn't get in outpatient settings. And so that kind of like stoked the fire and flame and kind of built a little bit of interest and niche in that way. And yeah, the presentation can be so confusing that it felt cool to like know it more and it more deeply and to help people. I have people all the time that have OCD. It's diagnosed, but it's still not necessarily treated in the right way. It's like it was understood, but like still not managed quite right. So I think I share that.
Yeah, I think it's a often misunderstood diagnosis. There are many things that can look like aspects of OCD that aren't OCD, or that get misattributed as something else but actually are OCD. It reminds me a little bit of what I loved about internal medicine when I was a med student, which was it felt like everything was this incredible puzzle to solve and try and figure out what was going on. And OCD is complex enough that it feels like that. And I too, as an adult resident before my child fellowship, had very limited experience with OCD. In fact, I can't remember if I ever saw an OCD patient when I was in my general psychiatry residency. It was really focused more on chronic severe mental illness, schizophrenia, severe bipolar disorder, schizoaffective disorder, serious personality disorders. And my guess is there was OCD in there and it just was not rising to the top of the like hierarchy.
Yeah.
It's not why they were presenting at the time, or it was being missed because it wasn't top of mind. And it wasn't until I got to my child fellowship that I got exposure to a lot more OCD and realized, oh, this is super interesting and kind of mysterious. And I don't think at the time I appreciated just how complicated it was. And the more you work with OCD patients, the more complicated you realize it is. But that's some of the fun and excitement of it, is trying to tease that apart and also help family members, other people in their world understand what it is. So, I've actually spent a lot of time over the years at schools doing presentations for groups of teachers on request, because there's a kid that I'm working with who has OCD or Tourette's that's in the school, and they're like, please help us understand this, because it's not obvious to people what it is.
What do you think some of those pitfalls are that are not obvious? Like if you were to kind of give a little overview of that, I think it's pretty misunderstood. And I think there is a lot of like, oh, I'm so OCD.
Oh, yeah.
There's these like, like it's made its way into this zeitgeist of like our vernacular, and people really, it's really not that. So, yeah.
Yeah. And I think that, we have so many examples of that type of thing. And the number of times I hear, oh, I'm so bipolar.
I'm so bipolar.
Or I had like a manic moment.
Yeah, I was manic. Yeah. Or, I think these phrases are out there and used in ways that are problematic. You can take it sort of lighthearted, but I think actually it dilutes what the meaning is. And actually for people with lived experience who are in earshot, they get very frustrated by it. I often hear from young people, I'm so sick of hearing my friend so-and-so or this other kid say how OCD they are. They don't know what that is.
A fun experience.
No, not a fun experience. And
treatment isn't fun.
And treatment is not fun, which we can get into. But I think that comment of I'm so OCD often comes from a misunderstanding of the difference between obsessive compulsive disorder and obsessive compulsive personality traits. It's often people who are like, oh, I like everything to be exactly right or perfect, or who are saying I'm so OCD. And that's just not OCD. OCD is unwanted, intrusive thoughts or repetitive behaviors that are ego dystonic, that are not in any way a positive experience for that person, versus the OCPD person who gets a lot of gratification from vacuuming 5 times a day and seeing how it looks at the end. And their distress comes from when somebody messes it up. And their belief is that everyone else should operate like this, and then the world would be good. Whereas in OCD, people are tortured by these thoughts, and they're not worried about, they're not vacuuming because they want it to be really nice and controlled and exact. They're vacuuming because they're worried that there's a germ in there that's going to kill them, or is going to kill their parent, or is going to cause the end of the world. And so I think that's a very common misconception out in just, I think, the general public about what it means to be OCD. Often people are just describing perfectionism. Which is not at all the same thing.
I'm wondering if you guys want to have a little, like, what are the differences of how it presents in children and adolescents versus adults? And are there differences?
Yeah, well, I mean, if you look at the epidemiology of OCD, there are two kind of points of kind of peak incidence. One is 9 to 12 years old, so that pediatric group. And then there's adult onset OCD, which comes online when a lot of other things come online around 19, 20 years old.
And sometimes postpartum too.
And sometimes,
Yeah.
yes, and sometimes postpartum. And they're very distinctly different in terms of genetics, in terms of comorbidities, in terms of risks. So, that pediatric population is generally a much more heritable form of OCD. The risk of, well, I think the research shows that for pediatric OCD, somewhere around 26% of them will have a family member with OCD. That number for adult onset OCD is much, much lower. I think it's around 15%. I may be getting that incorrect. So genetics play a bigger role. When you look at comorbidity across both adult and kids, there's comorbidity is the rule rather than the exception. But for kids, it's almost 100% of those kids, 98% will have some other co-occurring mental health issue. And adults, it's more like 70%. And there's much higher risk of disruptive behavior disorders like ADHD and ODD in pediatric kids, and a much higher risk of tic disorders in pediatric onset OCD versus adults. And then that has implications for what kind of treatment you're going to use and such. I'm curious what your experience has been.
Yeah, well, I mean, I don't know what it looks like actually for kids, so I only know how it comes up in adults. And it's interesting, kind of I'm curious about the phenomena differences, because some of them may be more taboo or stigmatized. Things that don't get shared as much might be intrusive thoughts or images or urges about self-harm or about sexual things. And I would imagine that comes from more development and exposure, and that it's probably less common in pediatrics. But yeah, in adults, like, there's a lot of, I've seen a lot of checking behavior. If I don't check my car 17 times, then it's going to get broken into and someone's going to drive it and they're going to murder someone, and then I'm going to get in trouble for that crime. If I don't flick the light switch 9 times, then something bad is going to happen to my mom. Intrusive thoughts about, germs and contamination is a very common one. Hand washing is the compulsive behavior. Showering excessively is the compulsive behavior.
I also think there's a lot, for adults, there's a lot of like thoughts, like, what if I did something? Like, what if I did crash my car into oncoming traffic and I'm going to do that? That could happen. And so I can't drive. There's these really big thought.
This image scary of me like just driving off the side of a mountain.
Totally. Yeah.
And so I stopped driving because I don't want that to happen. But there's no actual desire to do that.
Hurting a child is
right.
Yes.
Yeah. Avoiding playgrounds.
Yes.
Yeah.
But yeah, I'm curious if those things similar in kids, or if there's a totally different kind of constellation of the way the obsessional thoughts.
Yeah, it's a great question. I think that the younger onset OCD patients tend to have a higher risk of like fear-based anxiety. You see a lot of the contamination and stuff. And then also this sort of sensory compulsions and such that gets into this gray area of tics and what's a tic versus a compulsion, which we can talk about. Less commonly the kind of aggressive, intrusive thoughts and the sexual thoughts. But I think development definitely has an effect on OCD and the expression of OCD. And so I definitely see those in our adolescent patients, not so much in the younger kids. That version of young OCD also is more kind of male dominant. So the younger OCD onset, the higher the prevalence ratio or the ratio of male to female is versus later onset OCD where it's actually flipped. And that also ties with higher rates of ADHD, higher rates of Tourette's. And there's this kind of attempt, I think, to give people who are trying to assess and treat these young kids a little more open flexibility to conceptualize what's going on with them and conceptualize their treatment by thinking about some of these kids as having what's called Tourettic OCD, this idea that you can't always differentiate exactly what's a tic versus OCD, or sometimes people call it sensory OCD, where it's less about an intrusive thought. They may not even know why they're doing it, but it's just this intense discomfort, and they have to do it to get rid of that discomfort, or they have to do it till it feels just right.
Yeah.
Yeah. And if you get locked into, oh, this is OCD and it's different than tics, then you limit yourself to, okay, well, we just need to do ERP and we need to do an SSRI. And you might actually get a lot of mileage out of incorporating some of the behavioral interventions for tics, right? So it just like gives you more flexibility. Also, those patients, the studies show, often don't do as well with SSRIs as classic contamination OCD, and you might reach for something like an atypical antipsychotic sooner for a patient who has that, since that also treats tics, right? So there are definitely distinctly different phenomenological pockets, I guess you would say, with kids compared to the adult populations. But you can see anything. I mean, it's amazing the stuff that kids
I'm still seeing new
come up with.
Yeah.
Or I shouldn't say they come up with it, but that they come out with it. You know, they say, oh, this is what I've been thinking.
It's so sad. And the families are so affected by, like, I would imagine by the time a referral is made to treatment, that this has been really disruptive for a lot of households.
Usually it's at least 2 years of symptoms before people present for assessment and treatment, which is a long time given the severity and the impact that these symptoms can have. And, you know, when you catch it earlier, it's much easier than later. And there are many reasons for it. One of the differences, I think, well, I don't know that it's really a difference, but these kids are so embedded in family systems where, you know, sometimes because of genetics, there's a parent that has OCD themselves. The OCDs can get entwined. And so as a clinician assessing, you really have to assess for those family factors. And regardless of whether a parent has OCD or doesn't have OCD, the family system often gets completely wrapped up in managing this kid's symptoms, and they get into maladaptive patterns.
A lot of accommodating.
A lot of accommodating and avoidance, and really becoming a vehicle for the OCD. Like, it's kids get their parents involved in their compulsions all the time.
And in the reassurance.
Yeah. And so with kids, when you're assessing someone's OCD, you really need to also be assessing the entire environment that kid's in and how it is sort of reinforcing the OCD symptoms or not.
Can you give an example?
I think an extreme example, I had a patient at one point, I'm not here, who had pretty severe OCD in the contamination dimension or realm. And we were really struggling, and also suicidality and depression. And it was very messy, and we weren't getting anywhere. And at one point realized, in getting more detailed information from one of the parents that the other parent had severe OCD, which hadn't been disclosed to us, and that parent who we had been trying to get to participate in exposure therapy and help their kid tolerate this and see that it would be okay was, because of their own OCD, really unable to participate in that, and in fact was employing the child in their own compulsions because they had harm OCD and were worried that they were often running over people with their car. And so if my patient and this parent were in the car together, the parent would have the kid get out of the car and go and check that they hadn't run over somebody for that. So I think that's an extreme example, but an illustrative example of how the family system can play into this. On a simpler level, it's very common to have parents who, because of their kids' distress, are doing errors of kindness and wanting to make things smoother and better and get into a pattern of helping accommodate the 2-hour nighttime ritual, and are really uncomfortable with the idea of starting to pull that back because their kids get so distressed. And then the kids learn that if they get really distressed, their parents will fold and come back and help them. And so you get this escalating pattern and can end up with kids who are threatening suicide or getting really aggressive because they're so distressed by their OCD symptoms, and they've learned that that will engage the parents in rescue behavior for them.
And it's so hard to watch your kids struggle.
Absolutely.
That this momentary accommodation, little do they know that maybe, okay, this extended it 10 minutes. And in 3 months, 4 months, this is now an hour of our time. And then it's 2 hours, and it keeps, the slack keeps getting given, and parents find themselves like just at such a loss because then it gets so much worse once you start.
I mean, the good news is once you identify what it is, if you can bring the family along and really help them understand what's going on, we have treatments that work and that help. They don't help everybody, and we need to do better, but we have effective treatments for both adults and kids. And it's just a matter of identifying it and then, really working closely with the patient or the family or both, depending on the age. And I would argue with adults, we don't do a good enough job of involving partners, other family members. Just because they're a full-grown adult doesn't mean that other people aren't involved.
That's an interesting challenge, especially if there's stigma in the family.
Mm-hmm.
And so the person coming to treatment wants improvement, but then they have to do the treatment, which is basically like exposing themselves to that thought and not doing the thing that makes them feel better or is the antidote for the thought to reduce the stress. Then they have to tell the family member who doesn't really believe in the illness in the first place not to respond with reassurance, not to accommodate.
Right.
And it can get, yeah. But that's I think that's an important point you made.
The other thing that is really necessary, which is necessary for, I think, all treatments, is good coordination between all the care providers, because I have certainly seen where there isn't good communication and you've got one person undoing what the other person is doing because maybe they don't understand, they don't have as much depth of experience with OCD, and then in their sessions they're providing all kinds of reassurance and accommodation when a conversation between the therapist and the psychiatrist would have sort of provided an opportunity to say, okay, when they come in, this is what we're working on. And so you should feel free to tell them, like, I will reassure you one time and then we're not continuing this conversation. You know?
Do you mind speaking to that a little bit? And this could be for both of you. It's so counterintuitive, especially seeing somebody you love being so scared, or even maybe like newer clinicians or physicians that are just in, like going to their regular checkup, and it's like, oh, well, you're going to be fine. It's okay. You're not going to do that. Or don't worry. Yeah, why is that ineffective in OCD?
Yeah, it might be a good lead into like kind of
the
standard treatment approach too.
Yeah. Tee you up for a question.
Yeah. I mean, I think even in non-OCD anxiety, and I think discussing the difference there is probably important as well, reassurance is not effective. And it can actually make people feel really invalidated. Because they have a belief that is not of their choosing, right? And you're just saying, oh, it's fine. You'll be okay. So it's ineffective in that regard, but it also doesn't allow them to test the hypothesis that this thing that they're worrying about is actually true and is going to happen. And the treatment is, from a behavioral standpoint, is to give people the opportunity to see that this thing they're fearing is not going to happen. And to learn to have distress tolerance in the face of it can be anxiety. It's not always anxiety in OCD. So that's important as well, to understand that the affective states that OCD can cause can include anxiety, but it can include disgust, shame. There's a much broader range of affective experiences that we need to be monitoring for and targeting with patients and aware of, because if we miss that actually the issue here is not that they're anxious, it's that they're so ashamed, then we're not going to be able to have the same conversation. But they need to learn through exposure that the bad outcome isn't going to happen, or that they can tolerate the discomfort, because it's not always going to get 100% better, which is a whole other topic. I mean, I think a lot of people who are doing OCD treatment are starting to incorporate much more acceptance and commitment therapy principles into the treatment, recognizing that the goal for many patients is not going to be completely extinguishing the OCD thoughts. It's going to be learning to tolerate them and keeping an eye towards, like, what is your purpose in life? What's meaningful for you in life, and not letting it kind of sidetrack you from that. If we're shooting for zero OCD, we may actually be setting people up for feeling like a failure in the process. As wonderful as it would be to have OCD gone. I mean, I think my experience more often than not is that when people get better, the experience, I mean, I have some patients who say, no, I don't have any OCD thoughts anymore. That's amazing when that happens. More often than not, I hear, yeah, they're still there, but they don't really bother me. I can ignore them.
They lose relevance.
The valence is lower, and they feel like they can manage it in their life in some way. And since that's the more common outcome, I think making sure that that's part of the treatment conversation is important as well. But coming back to why not reassurance, I think that the core issue is just that you're not allowing them to learn that this thing isn't going to happen. And so by doing that, actually what happens is people get like momentary relief. Oh, okay, yeah, this bad thing isn't going to happen. And then it comes back up, and it often comes back higher. So reassurance can actually increase somebody's distress and anxiety ultimately, because it's not lasting. It's not getting at the core issue behind it.
This is really tricky, because when you're coaching parents, when you are managing a system of people and a child, which is, I think, so common, children think their parents, something bad is going to happen to their parents. Or that, especially if there's like a big transition in a kid's life, and then all of a sudden this fear comes out of maybe seemingly nowhere. And then the parents do all this upfront accommodating and assurance that, nothing's going to happen to mommy, or that dogs are safe, or that planes are safe, or they saw something on the news, or they heard something. And then now there's this outsized fear that something bad is going to happen that's also tied to some avoidance of something, or some kind of ritual that's happening, right? And I think it's really hard for families to know exactly at what point not to, overly assure, and then for the kid and the household to not accommodate. It's so tricky.
Yeah, it is. It's really hard for families, because parents want to swoop in and help their kid feel comfortable. And it's really hard to sit there and let your kid suffer. I mean, I think one of the other challenges with reassurance is that if you reassure and reassure and reassure, and then something bad happens,
Right.
your credibility is out the window, and you can't 100% say that nothing bad's ever going to happen. And so I think that's a trap as well.
Or
That's
that
an important
I think
highlight.
there's also some presentations I've seen in kids and teens is there's especially in religious households, there can be a lot of fear of being wrong and the shame that you were talking about, that God or some higher power is watching. And if there's this, then all these kind of other things start developing as a result. And the disturbance gets really high.
Yeah. I mean, you're touching on a different topic, which I think is important in terms of, I think it actually comes back to assessment as well and treatment planning. You really have to understand the culture of the family, and these things don't happen in vacuums. And we need to be really careful not to put our own cultural assumptions at what's going on in a family. This often comes up around religion and OCD, scrupulosity. And so I mean, I will actively request and usually get permission to talk with pastors, rabbis, whatever, who know the kid, the family, to really understand, like, does this look out of bounds to you? This kid is praying this much. This kid is doing all these things because of their fear of offending God, or that they're going to go to hell. And they're invaluable collaborators. I've worked with a lot of ultra-Orthodox families in New York and had, rabbis in that community who could very clearly say, no, this is like, yes, this kid's job is to go and study Torah and, be a religious scholar. And this is way out of bounds. Because OCD it's not just a little bit more of something. It is excessive.
And typically irrational in some degree.
Yeah.
Yeah.
So I think the key to OCD assessment is, well, I think all psychiatric assessment really is like getting as much information from as many informants as you can. But I do think OCD has this particular kind of valence around what's important in a family's culture, not just religiously, but in other ways as well.
Absolutely. Yeah.
For the listener, kind of just lay out the landscape of what an ideal treatment scenario looks like for someone with OCD from a therapy and a medication standpoint. And then we can also get into some risk assessment as well.
Yeah, that would be great. I think that treatment for OCD depends a little on severity level. And so the recommendations, generally speaking, for more mild to moderate OCD would be to start with cognitive behavioral therapy, specifically exposure with response prevention. I think for the people who aren't clinicians listening, exposure with response prevention is essentially working with a patient to expose them gradually to the things that they're fearful of and prevent them from doing whatever their rescue behavior is, the thing that they're doing to try and prevent that bad thing from happening. So an example of that could be you've got somebody who has contamination fear and they have to wash their hands for 15 minutes before they can feel like they're clean. And you're going to start working on reducing that amount of time and getting them to tolerate the distress that they feel around the risk of contamination, and then learn that nothing bad happened. They didn't get sick. They didn't die. The world didn't end, whatever their particular fear is. And you're tracking over time sort of the response to that intervention in terms of their distress level. And it used to be that we would do this with the idea that you're trying to march down on their distress level each time. And that thinking on that has shifted somewhat, in that our goal is to improve their ability to tolerate the distress and that you're not always going to see a dramatic reduction in those distress scores. And in fact, setting them up for a feeling of failure if they're not getting down to zero distress. You're building their capacity to tolerate that distress.
It's like a muscle.
Yeah, it's definitely, it's absolutely like being an athlete and building new muscle or new skills. So that would be the starting treatment. That's gold standard therapy for most OCD. There are some OCD kind of types that don't respond as well to ERP. Contamination is the easiest with that respect. The sort of like checking behaviors and aggressive is somewhat less responsive just to ERP. You get up into like hoarding, which is now a separate disorder, and traditional CBT does not work for that. You need really specialized CBT that is more focused on actually like executive function skill building,
the sorting,
and decision making and sorting. So like what that exposure therapy looks like really depends on the type of OCD, but that it would be the starting place for a more mild OCD. Once you get into that moderate to severe category, the research is pretty clear that a combination of an serotonin reuptake inhibitor of some sort and ERP would be your first line treatment. But we also know that somewhere between 40 and 60% of OCD patients don't respond to an SRI alone. That rate is better with the combination of ERP and an SRI. But because of that, there are whole algorithms for how you think about next steps. Typically, you would try one. I think the important thing for people to know about OCD medication is that the dosing is higher. Not for everybody, but you shouldn't be scared about pushing doses. So for instance, the FDA max for sertraline is 200. In OCD in adults, 400. You could, it's not an FDA approved dose, but that's not uncommon and difficult to treat OCD. Kids go up to 300. Sometimes they don't go higher than that in teenagers.
There's where for younger folks, if you still go above FDA, but maybe not as
high. Yeah.
Okay.
Prozac up to 120. So like push your doses before you give up on a medication, and also give it more time than you would for depression or for non-OCD anxiety. So, at least 8 to 12 weeks, sometimes more than that. There's some evidence that shows that on a given dose of SRI, you can continue to see improvement over 6 months with OCD, which you wouldn't expect for depression or for like GAD or something like that. So give it time. Don't be scared of bigger doses.
Which is important, I think, to encourage patients and families that if the medication hasn't worked and you're, for example, Zoloft, you're on 100 milligrams of Zoloft and it's been 2 weeks and it's not working, we're not anywhere close to considering it an adequate trial.
I set that roadmap up day one. So when I'm doing my treatment recommendations and feedback session, and we're going to start an SSRI, I explain all of that to them. Like, we typically need higher doses. I lean on the research. You need to know your research. What are the average doses in the treatment trials for somebody that age with OCD? So like the POTS trial, sertraline dose, kids were average about 12 years old, and that average dose was around 138 milligrams, which parents are often like, what? That sounds really high.
If you pop that into ChatGPT might tell you that that's...
Right. And often they've heard from other providers, go, start low,
right,
go really slow.
Right.
And yes, and when you've got somebody in real distress with OCD and you know that the doses that you need typically are higher, I lay that out for families at the beginning and give them that range. And I say, we probably aren't going to get to 300. And I don't want you to be surprised when at 100, I say, you know what, I think we should go up. The more you can give people a roadmap, the less struggle you're going to have down the road when you're making recommendations. And they're like, wait, why are you doing this?
And there's the psychology of it too. Like I've had people that they feel like really sick if they have to take the maximum dose. And so they'll either see someone that maybe isn't as versed and they'll get the 200 milligram FDA max of Zoloft and be like, all right, well, it didn't work. Or they'll internally say, oh, like, I don't want to be on the maximum dose. And so I tell them, well, your maximum dose is actually 400.
Right.
So you only got 50% before you stopped. And so that kind of helps shift the...
Yeah. Yeah, I love that because it really is setting expectations, right? And when we don't do a good job of setting expectations, we sort of set ourselves up for a difficult road and just misunderstanding with families. But if you understand the dose ranges that you should be talking about and you understand the duration of an adequate treatment trial, then you know better when to say, okay, this isn't working. Let's switch to a different medication, which would typically be either another SSRI or clomipramine. And then if that's ineffective, thinking about augmenting with something like Abilify or risperidone. And that also depends a little bit on what type of OCD you're talking about, because if it's this kind of Tourettic OCD or there's comorbid tics, you might grab an atypical antipsychotic sooner to treat the tics. And there's some evidence that that kind of Tourettic type of OCD just doesn't respond to SSRIs as well. So you might go there faster. And then there, for adults, there's much more research into other augmenting strategies than we have for kids. And so there are other things out there that you might consider if you've tried all the standard stuff and you're not getting there, but not until you've tried all the standard stuff, because the research is still pretty thin and growing. And there's some stuff that looks promising, but it just doesn't have the same level of quality research behind it. I think one of the newer things, which is not available in every community, but it is available around here, is TMS for OCD.
Do you know, is insurance covering that you've heard of?
It's a good question. I don't know the answer to that. I think it would if you've failed all the other stuff.
If there's enough evidence, yeah.
And there are very clear guidelines for when TMS for OCD is warranted.
Okay.
And it is very much about having failed multiple other things. So I think it would be covered in that in that situation, but I haven't run into that issue. And, I think you also need to know that TMS is not a standalone treatment for OCD. It's paired with ERP, and it has to be paired closely with ERP. You're going in for a session where you do your exposure, and then you get TMS right afterward. The TMS is to affect that sort of fear extinction loop. And it has to be paired in that way. So if you're just sending someone for TMS, I don't think TMS providers would just do standalone TMS, I hope, but be aware of what it should look like.
Well, and I think this is a good kind of lead up to what is the gold standard of the multidisciplinary care that goes into treating OCD in kids and teens. What should that look like?
I think it depends on your community and what resources are available to you. But, if all things were available, I think the gold standard would be, an experienced psychopharmacologist who knows what OCD is and what the treatment protocols are, and a therapist. I don't care what their credentials are, but who has depth of experience in OCD, that understands exposure with response prevention and can explain what that is. The number of times I see kids who they're like, well, we've had CBT, and I ask what it was, and there was no exposure work done is sort of troubling. And so having a therapist who really understands that exposure is the most important active ingredient in OCD treatment and non-OCD anxiety treatment. Those are like the most critical components. I also think the gold standard multidisciplinary team would include close collaboration with the kid's school, the parents and the family, like we were talking about. You're addressing those family factors. There's a lot of communication between all those people. It's really important to include the school, because if you're doing exposure work for a kid and then they spend 8 hours a day at school and it's all being undone at school because the school doesn't understand what's going on and they are allowing the OCD symptoms to be reinforced, what you're trying to do outside of school is going to be completely ineffective.
Yeah.
So, you have to include all these people. For kids who spend a lot of time with grandparents or other caregivers, they need to be in the know. So there's a lot of work with families about stigma and not letting that get in the way of effectively communicating with the other people that are in a kid's circle about what's going on, because every OCD is really good at finding the weak link. And so if there is a weak link, I guarantee you that kid is going to be going to that weak link to get what they feel like they need from the reassurance standpoint. So communication.
Yeah.
Makes sense. I was curious about the atypical antipsychotics, or kind of the dopamine blocking agents, and there are a lot of ways to classify. But the aripiprazole, risperidone, Abilify, Risperdal, like when you mentioned the Tourette's OCD, it's probably a good application. When do you think about it as an augmentation, as a second medication to the primary SSRI for pediatric cases?
I mean, if a kid has tics, I'm much more likely to go there quickly.
First or early.
Or if it is a kid where it's really hard to differentiate, is this a tic or is this OCD? Given what the research shows about the effectiveness of going with an atypical versus an SSRI in those, I might actually start with an atypical. And I kind of like, even saying it, I kind of get an upset stomach because we know the side effects are, concerning, to say the least, or can be. And so sometimes I'll do an SRI just to say, well, let's try it. It's the safest thing to do. I don't know if we're going to get far. Let's give it a little bit of time and just see if we're getting anywhere. But we may quickly pivot to do this. I don't generally, sort of outside of the Tourette's kind of OCD side of things, I don't reach for them until I've already tried
like 1, 2, 3,
at least one, if not two SRIs at a full dose for enough time. If I have a patient who is on a high dose SSRI and it's been enough time and they've had a reasonable response, but they're still struggling, I might in that situation say, well, let's just add a little bit of low dose Risperdal or Abilify and see if we can get you over the hump instead of starting over with a whole other SSRI versus a patient where I'm getting essentially little or no response. It's tricky though, because actually there's some research that shows that the patients who have little or no response to an SSRI are better responders to atypicals than the patients that have had a partial response. Yeah. And it may be that it's because they have a different kind of OCD. And so.
Yeah, it makes sense too, because the mechanism isn't necessarily that different from going to Zoloft to Prozac. If one didn't work at all, it's an interesting question. I think I've practiced similarly in adults where it's if they've gotten that partial response and we're at a really high dose with adequate time and there's still a lot of functional impairment, that we'll think about layering in a low dose of an atypical antipsychotic.
I think another time,
or if there's actually comorbid bipolar disorder is maybe when we would layer, I don't know how much you see that in kids.
That's a really important thing. I mean, I think you have to look at the comorbidities because you might reach for medication sooner if somebody also has co-occurring depression or bipolar disorder, and you'd think differently about those medicines in those situations.
Yeah,
absolutely. We don't see that as much in kids, but we do see a lot of like oppositional behavior or ADHD and non-OCD anxiety is more common in kids with OCD than adults with OCD. I mean, it's common in adults with OCD, but it's even higher in kids. So all of those certainly have an impact. The other reason I might reach for an atypical sooner than later is if there's poor insight and a lot of rigidity in their thinking. So it's all these kind of nuances. around it.
The listener is in the mental health world is wondering if there's OCD and ADHD, how does that change the approach, especially with kids? If it does at all.
Yeah, I don't know that it does so much, other than it makes me really be on the lookout for other things like tics, because that's a trifecta that happens together. So I try to do due diligence anyway, but make sure in that situation that I'm really drilling down saying, like, are we sure we haven't seen any tics? Because that'll change maybe our treatment strategy a bit more. But other than that, it doesn't necessarily affect it. I mean, I think the question in that case is often like, where do we start? What do we start first with?
Yeah, what's the biggest impairment?
What's the biggest impairment? I think you ask 10 child psychiatrists, you get probably 10 different answers. I think impairment's the biggest thing from my perspective, but also with ADHD, sometimes I'll choose to treat that first simply because if it's going to respond to a stimulant, we're going to know right away, and then we can move on to treating the OCD. And then we've spared that kid 3 more months of struggling in school because of their ADHD while we're figuring out the OCD. Because it's going to take longer time probably to figure out the OCD medication than the ADHD.
Yeah, much longer.
Medication. I think coming back to the comorbidity piece of things and depression, this is like my soapbox. I want people to really very carefully assess for comorbidities when you have a patient with OCD, because it is the rule rather than the exception. And depression is extremely common in OCD. And it raises the suicide risk in OCD. There used to be sort of a general belief that OCD didn't confer any elevated risk for suicide.
Yeah, I feel like I got a lot of that teaching, or that maybe not no risk, but that OCD patients are really that high risk for suicide because it's ego dystonic. They actually don't want to hurt themselves.
Right. And so this is a really important point. And I see it create all kinds of confusion in emergency rooms or schools or wherever, where they get sent by a place to an emergency room because they're suicidal. Both things can be true. So that's the other important thing. Don't fall into the trap of, OCD isn't a risk for suicide because OCD thoughts are ego dystonic and they're not going to do anything. And don't fall into the trap of they're saying these scary things and for sure they're at risk. So OCD, we now know that actually OCD patients are at a significantly elevated risk for suicide above the general population, regardless of whether they have depression or not. So that old kind of mythology has been proven incorrect. If you add depression and OCD together, then the risk is about equivalent to those with depression. So it's quite high. And you have to drill down even more into the type of OCD that people have. The patients I worry the most about are the patients who have intrusive, unwanted thoughts that are so counter to their morals and who they think they are as a person. So intrusive pedophilic thoughts, murder, homicide thoughts. Those are the patients who I worry a lot about in terms of suicide, because they're so tortured by this thing that is antithetical to who they are in the world. And suicide can be seen as the only escape.
Yeah. The pedophilia thoughts are ones that I've often had to have people in and out at a higher level of care programs, and the suicidality is very concerning.
It's intolerable, understandably. And that's different than the patients who actually have intrusive, unwanted thoughts of killing themselves. And that's where it gets, I think, often confused in the emergency room. And they'll say, this person has suicidal thoughts, and you actually talk to them. And as opposed to, I'm thinking of killing myself because life is intolerable and I don't want to be here anymore. It's, I'm having thoughts of killing myself and I'm so distressed by the thoughts of killing myself and I don't want to do it. That patient, I'm actually not worried so much about them killing themselves.
That's kind of probably where the lore comes from, or that older instruction that there's no risk. Yeah.
So again, it's just,
I think that was a really good
assessment
layout of the nuance with that.
And easy to even get like, both of you were saying how many years of training, how many patients you've seen, and yet the clinical picture of OCD is really complicated and takes specialized training and experience and exposure to what's coming in and having really good mentorship.
And use standardized measures. I'm like, this is a place where I think it's important in our field in general, but with OCD, because it can look like so many things, you're not on your own going to think up this laundry list of potential obsessions and compulsions and go through it with every patient. And that would be so time consuming.
Like what, 30 or 40?
I don't actually know the number on the Y box.
Yeah.
Cybox use that, because the other way I find it really helpful is it can help facilitate the conversation, shame, and stigma. I always lead by saying, I know these things are hard to talk about and you're embarrassed, and they're so common that we've created there's this list that we all use, because you're not the only person who has this, and that can be freeing for patients and a lot easier than you just peppering them with a bunch of questions. I want you guys to be my therapists.
Oh, that's really sweet.
I want you to be my therapist. We got to be friends. It's better.
Yeah. True.
That would mess that up.
Yeah. We can be friends and provide therapeutic support.
There
but
you
can't
go.
do the other way around.
Justin, thank you so much for coming on today. This was just such a privilege, and I have a feeling you'll be back.
Yeah, I would love to. I'm honored that you asked me to be here.
I think we need a whole other episode on tic disorders. Yeah.
Let's do it.
I think we might have several with just
Yeah.
like routine visits.
I know. It's an excuse to hang out with you.
Yeah.
Thank you so much for coming on. If you've made it this far into the episode, don't forget to like, subscribe, repost. I'm Kaila.
And we'll include your links in the show
Yes,
notes.
we'll include links.
Yeah. I'm Dr. Sir.
Thanks for listening today.
Until next time.
Bye.
Thank you.
Bye-bye.